there is an increased decreased glucose uptake, increased oxidative stress, endothelin reticulum stress, and by means of various pathways, the abnormal glucose metabolism and insulin resistance goes for cardiomyocyte apoptosis and finally myocardial fibrosis, thereby resulting in systolic and diastolic dysfunction, further resulting in end-stage heart failure. So, hyperglycemia in a nutshell causes myocardial hypertrophy, fibrosis, cardiac remodeling and heart failure. So, the diagnosis, it's a challenging, no specific markers, patient will be silent and the complications overlap. So, you need to find it early in the disease. You need to find out when the patient, you can see from this slide, the asymptomatic individuals you need to identify, because the transition from the asymptomatic individuals, stage A is the risk factor. Diabetes per se, it's a risk factor. Apart from that, diabetes, obesity, all the stage A. And stage B, you can see the transition from stage B. Immediately, from stage B to C and D is very rapid with the diabetic population. So, we can catch hold of these patients earlier by means of scores, risk scores. There are two scores, ARIC score and WATCH-DM score. You can have a calculation and you can catch them early so that you intervene them with the tight glycemic control as well as the newer SGLT inhibitors, which I will be discussing in the forthcoming slides. So, you need to catch them very early in order to prevent them going from a stage B to stage C and D. You should catch hold them as early as possible in asymptomatic diabetic patients, high risk category, as you identify them by the risk scores. There we have this newer modality of.
Thank you HOD sir for lecture. We welcome you occupy the chair sir, and thank you for saving the time also. Over to next speaker, Dr. Magadevan from Chennai.
Using a fixed drug combination of metoprolol telmisartan in people with hypertension with ischemic heart disease by using a ambulatory blood pressure monitoring. It's a phase 4 trial, prospective multi-center trial that was conducted in Indian populations by Indian drug. So hypertension at a glance, we know that the hypertension is the largest disease, chronic disease across the globe. Nearly 1.3 billion people are being affected. In India, nearly 21% of females and 24% of adults suffer from elevated BP. And hypertension is leading cause for stroke by 57% and acute coronary syndrome by 24%. The ambulatory BP monitoring is one of what we use CGMS for diabetes, revitalized the treatment strategy and protocols by using this tool for day-to-day assessments. So ambulatory BP monitoring is very effective in evaluating the hypertension in patients with significant variations. When there is significant variations between the home monitoring of BP and in-clinic BP, so ambulatory BP monitoring becomes a standard tool to assess the exact picture where the patient is. And also it can be used to set the target for the individuals and also therapy based upon his BP surge and downs. So accuracy of BABPM is very good. It predicts the cardiovascular events much more far. It correlates much more with the CV events in the individuals, and also identify the masked hypertensions, white coat hypertensions and dippers and non-dippers, which is very vital in diabetic individuals, because diabetic individuals are non-dippers, they are at risk of developing CV events, maybe vascular at level of the renal or at the level of the brain and heart, so on. Also guides the therapies, which drug shoots for these patients and what the drug, what the dosage can be extrapolated by assessing the ABPM tool. And fixed drug combination, any chronic ailments recurrence, fixed drug combinations. The drugs should be very complementary in actions and synergistic in actions without any inducing side effects. So any fixed drug combinations, if you put together, they reduces the pill burden and reduces the dosing frequency, also improve the compliance, which is very, very vital when you treat chronic ailments. So metoprolol works at the level of beta blocker as a cardiac selective beta 1 blocker, and telmisartan works at the AT1 receptor, which is having synergistic combinations without any adding adverse events. By combination with the drug, what we used in this trial was metoprolol here. How it differs from the other competitive brands, it have a unique patented wrapped matrix technology that makes the deliver the two drugs at a different angles, that makes the control and consistent release. You can see this is the picture of the metoprolol. So the pink color, it is encoded by a partially permeable polymer coating. The pink color is an telmisartan, which is incorporated in explodable polymer. So it releases immediately into the bloodstream, And next is the metoprolol was incorporated in a controlling polymer. So that stands for its 24 hours profile of the molecules. Let us focus on the study what was conducted in Indian subset of population. This is a control study, was a phase 4 trial, open label, multicentric, non-comparative treat to assess the efficacy as well as tolerability of this molecule in patient with angina, stable coronary artery disease and hypertension. So 88 patients were enrolled in the studies. A number of sites incorporated in India was 7. The study period of 10 weeks, of which screening period 2 weeks and treatment period is 8 weeks. The primary objective is to assess the efficacy of the molecule, and the secondary objective is to assess the tolerability of the molecule in patient with the hypertension with ischemia disease. The molecule used in this study is metoprolol 25 mg as well as 50 mg. The initiation of the molecule as on the discretion of the physician based upon his BP, based upon his pulse rate, this molecule was started. So the study design is the first visit was screening period that was allotted for 2 weeks, and the next visit there is a day 1 for the initiation of molecules. The second visit the patient was started on metoprolol 25 or 50 depending upon the patient's pharmacodynamic profile, and next visit was followed by 14 to 28 weeks where they will assess what is the side effect happening because of the drugs, whether the drugs needs much more titration, or when you want to rescue therapy to push the BP control to less than 130/780 as per the ESC guidelines. And the fourth is the early termination or end of the treatment or the study results. The inclusion criteria is any adult, female or male willing to give consent for the participation, hypertension with established CAD, stable CAD, and BP should be in the higher range of more than 130, 140 for a systolic and 90 for a diastolic BP, with either you do it the clinical or ambulatory BP monitoring, and patients already taking these molecules can be incorporated if they are willing to participate in the studies. Exclusion, all the renal impairment, other hepatic impairment, patient in metabolic acidosis, thromboembolic episodes were excluded, and this is the primary endpoint. The primary endpoint to check the mean 24-hour ambulatory BP monitoring, both systolic and diastolic is taken into consideration from the baseline to 8 weeks. The second endpoint is responders time, how much amount of people are responding to the target therapy of target of less than 130/80, and subdivision is what happens last 6 hours of therapy, because you are going to give the medication in the morning, what happens the last 6 hours to assess the shoulder effect of the molecules, and also they compared what happens first 6 hours and last 6 hours, any peak or trough effect is there. So last 6 hours were incorporated, and people with the first 6 hours and last 6 hours BP difference was computed for these patients. The efficacy aspect, the short term variability assessed with so much of parameters which you are going to deal, it may be your more statistical significance. The short term variability, long term variability of these molecules in terms of BP control, this will be told in a nutshell. Now last, in addition to that, what happens, the BP happens when you increase the dose from 25 to 50 mg, and what will mean 24 hours BP with people taking high dose when the start of the drug itself, and what happens for the escalation of the molecules. So determination of sample size, many of you may ask why 88 was chosen there. Incorporating the knowledge from the similar cohort or similar prototype study, they found that standard deviation to optimal have a standard deviation of systolic BP and diastolic BP of even 10 millimeter change. They incorporated to keep the type 1 error as 25. Nearly 66% is a number of 66 patients sufficient to conduct a study. To the dropout of 25, they incorporate 88 subjects can be needed for this study. So the number of people incorporated is 88 mainly because of arriving the statistical analysis and the previous knowledge we had from the previous similar prototype study conductor. This is demographic which is mimics as what we see in day-to-day practice, 50-year-old male or female coming with high BMI or high waist ratio with uncontrolled diabetes. So primary efficacy point is clearly told. The change in 24-hour BP monitoring with this fixed combination will phenomenally have statistical reduction of more than 15 millimeter of mercury in systolic BP and 10 millimeter mercury in diastolic BP. This research was obtained from ambulatory BP blood pressure monitoring. What happens with clinical BP monitoring, this also shows statistical significance. So even clinical BP monitoring has incorporated this fixed combination. There is a drastic fall of BP by 13 systolic and 7 diastolic BP parameters. And rate responders, many people are able to achieve the target BP of 130/80. When you go by ABPM, nearly 36 patients are able to achieve the BP control. In clinical BP, it comes around 10. So the drug is safe, the efficacy has been proved. The people on this combination had able to achieve good, large number of people are able to achieve the target rate. So when you analyze the amount, the number of recordings for 8 weeks is 4168. Out of 4168 recordings, nearly 32 recordings were within the heart rate of 70 and parameters. That is nothing but the average of daytime BP with the nighttime BP over 24 hours. So there should not be any change. The morning BP and the evening BP, the average BP should not have any difference. So when there is no much difference, it shows the drug is very good. It acts 24/7. There is no variability at all. Another is coefficient of variation. They are assessing the standard deviation to the mean BP level, which what we have statistical analysis. That also should not have any much difference. The standard deviation is different from mean BP. Then the study is not, the BP is not well under control. Both the things shows it is a standard deviation. Then the BP standard deviation of the BP measurements to the mean BP, there is no much difference at all. And 24 weight BP, that is nothing. What happens in the morning BP 9 o'clock, 11 o'clock? What happens is nighttime BP 9 o'clock, 11 o'clock? There is no much difference. There is no difference at all between these two. So secondary endpoint, whether the weighted mean of daytime or weighted mean of nighttime or even 24 hours, there is a drastic BP. That it directly shows the molecule works 24/7. There is no peak or trough in the BP level, so keeps the BP at target level, and that can be monitored by the ambulatory BP monitoring. Real variability. So average real variability, they will watch along with BP parameters. What happens at 8 o'clock? What happens at 9 o'clock? What happens at 10 o'clock? And every hour they will records. There is no much difference in the BP levels by 9 o'clock or 10 o'clock or 11 o'clock. It shows the BP has been kept under the control, under the well level. And it's a delta statistical BP is a difference. What is the maximum BP of the individual? What is the minimum BP of the individual recorded on the daytime? So they want to assess what is the difference levels. The difference is not much wider. It shows the molecule is very good in terms of reduction, all the parts of BP control. So the short-term variability is well under control. It speaks the molecule, the BP variability is not that much when you use these molecules. So here you can see that what happens in the last 6 hours compared to that of early morning BP can clearly show that there's a drastic, even the molecules works at the later part of the times. Even if the patient is taking the BP molecule by 8 o'clock in the morning, even early morning 4 o'clock or 6 o'clock, maybe you may expect a trough level, that is a shoulder effect of the molecules. That this time many of the CV events happens. So it's not so. If you give this molecule extended release along with the telmisartan, the drug profile is very well. Even the early morning BP surge has been very optimized as comparable to the early 6 hours of the BP surge. This clearly shows what happens the profile. You can see the upper column is the baseline. You can see that 148 was the mean BP in the morning and late hours is 144. But after adding the medications, both BP is well under control. The first 6 hours, 133 is at par matchable with that of the last 3 hours, 131. It also incorporated the diastolic BP counterpart also. So the molecule is going to be justified in terms of reduction of the both 24/7 control without any variations. How we are going to long-term variability? These also has been some sort of index has been used. One is the Tovey index, another is the smoothness index. It is nothing but they change the calculate hourly BP with the standard deviation of the BP reductions. At the same thing, the Tovey is calculated by mean BP reduction towards the standard deviation of reductions. They have clearly found out there is a statistically significant improvement in the Tovey index as well as smoothness index. It speaks about the good quality of the molecule. Even the long term, the BP control will be maintained. No need for acceleration of the medications or no need for rescue medications into play for optimal BP control. Subgroup analysis, they want to know what happens for the BP when you want to go for 25 mg, when you want to go for 50 mg of metoprolol. They are clearly told, irrespective of the drug molecules, the BP reduction, both the systolic and diastolic, is well under control, whether you use 25 mg or 50 mg based upon this. And heart rate also, the heart rate control, achieving heart rate of less than 70 is also well narrated by giving whether for low dose or high dose. Both the drugs works in angle. And adverse events is very minimal adverse events. What is skin related, subcutaneous related insurance documented in 5% of people. None of the major adverse events is noted. In study conclusion, the ambulatory BP monitoring is very vital as what we do CGMS to assess the exact picture of the BP of the individuals. What is the diurnal variations is there, what is the mass type condition, what is the white coat appearance, where you want to intervene, so much of things. And this is one of the states that uses ambulatory BP monitoring for a 6-8 weeks period. They found out this fixed combination of metoprolol succinate with telmisartan had drastic BP reduction. There is no day-to-day variability. The primary endpoint is been suffixed. The tolerability profile is very good and side effect profile is very minimal at part compared to the other placebo effects. Thank you for this was published in World Hypertension Congress 2025 held in Chennai. Thank you for the patient listening.
Control of the BP with the fixed dose combination of the drug metoprolol. Now the forum is open for discussion. The diabetes and cardiology always co-associates because MedPub Cardiology and Cleveland Clinic address diabetes as caramel cluster disease comprising the cardiovascular, renal, adipometabolic, eye and liver diseases. So we have this forum for the diabetologists, cardiologists have spoken, and any discussions we are open to. Thank you very much, sir.
Thank you so much, Chairperson.
Sir, for
Can you advise telmisartan metoprolol without this technology to have the same type of BP reduction in all patients? And I feel that telmisartan bisoprolol BP reduction is better than this telmisartan with metoprolol. Bisoprolol is better, no?
No, there is no head-to-head comparisons of telmisartan, this combination, that combination.
Yeah, that
As
is
rightly
what I
pointed
said.
out, the preparation of metoprolol is the major concern for to prove the mortality benefit. That is, initially metoprolol was given as metoprolol tartrate. That
Yes.
doesn't have any CV benefit. They
Definitely.
moved to metoprolol succinate.
Succinate,
That
yeah.
may be the reasons for the CV benefit.
Okay. The benefit is because of the metoprolol succinate
Yes,
and the type of release of the metoprolol and the telmisartan.
Yeah, they're using different technology in this metoprolol. They want to assess the effects.
thank the organizers and scientific committee for the opportunity, and to thank the both all the three speakers for